Welcome to Teaching Service Hospital Rounds. Today we take on dysmotility and nutrition. This is the group of problems where the gut looks structurally normal, but simply does not move the way it should. We will meet 6 patients. Each case opens with a history and a physical exam. You get a moment to commit to a diagnosis. Then we reveal the answer and teach the entity behind it. We cover functional gastrointestinal disease and irritable bowel syndrome, cyclic vomiting syndrome, gastroparesis, paralytic Ileus and Ogilvie syndrome, constipation, and nutrition in critical illness. Let us start with our first patient. Have a piece of paper ready. Commit to an answer before each reveal. You will remember it far better that way. Here's what you should walk away with. First, define a disorder of gut-brain interaction and explain why that phrase replaced the older word functional. Second, apply the Rome 4 criteria to diagnose irritable bowel syndrome at the bedside. Third, sort a patient into the constipation predominant, diarrhea predominant, mixed, or unclassified subtype. Fourth, choose therapy that matches the subtype rather than treating every patient the same way. And fifth, recognize cyclic vomiting syndrome, including its strong link to cannabis and to migraine. Keep these in mind as the cases unfold. Notice how many of these are pattern recognition rather than test ordering. That is the theme of the whole hour. The second half of our objectives. Sixth, diagnose gastroparesis and know exactly what the emptying study has to show. Seventh, separate a paralytic Ileus from a true mechanical obstruction. Eighth, manage Ogilvie syndrome and recognize the cecal diameter that means danger. Ninth, work up constipation using the Rome 4 definition and the 4M framework for secondary causes. 10th, build the stepwise constipation ladder from fluid and fiber all the way to the newer secretagogues. And last, choose between enteral and parenteral nutrition in the critically ill patient. Let us begin. Several of these hinge on a single number or a single drug. Those are the details we will slow down for. Our first patient is a 28-year-old woman. She has had lower abdominal cramping for about 8 months. The pain is crampy and it eases after she moves her bowels. Some days her stools are loose and urgent. Other days they are hard and difficult to pass. She feels bloated most afternoons. She has no weight loss, no blood in the stool, and no symptoms that wake her at night. On exam, she has febrile with a soft abdomen and only mild left lower quadrant tenderness. There is no mass, and the rectal exam is normal. Her blood count, inflammatory markers, and celiac serology are all normal. So what is the diagnosis? Take a moment before we go on. Ask yourself which findings here are doing the real diagnostic work. This is irritable bowel syndrome, the mixed subtype. Notice what made the diagnosis. It was the pattern of the history, not a test. Recurrent abdominal pain that improves with defecation, a change in stool frequency, and a change in stool form. She has no alarm features, and her basic labs are normal. So irritable bowel syndrome is a positive clinical diagnosis. It is not a diagnosis of exclusion that demands an exhaustive workup. The next step is to name the diagnosis for her, explain that the gut and the brain are miscommunicating, and start therapy aimed at her dominant symptom. Now let us build the teaching behind that answer. Notice too that she does not need a colonoscopy. Her age and her clean history do not call for one. Start with the umbrella term. Functional gastrointestinal disease describes recurrent gut symptoms caused by disorders of gut-brain interaction rather than by a structural cause. The Rome 4 criteria describe roughly 30 distinct types, and irritable bowel syndrome is the one you will see most often. The key word is interaction. The bowel is not broken, and the patient is not imagining the pain. The signaling loop between the enteric nervous system and the central nervous system is disordered. That framing matters clinically. It changes how you counsel the patient, and it points you toward therapies that target motility, sensation, and the brain-gut loop. And notice that the word functional never meant imaginary. Follow the loop on the screen. Start at the top. The brain sends signals down through autonomic pathways to the gut. Stress and emotion travel on that same wire. Follow the arrow down to the gut wall. Here, the enteric nervous system controls motility and secretion, largely on its own. Now follow the arrow back up. The gut sends sensory traffic to the brain about stretch, about pain, and about luminal content. Notice the 3 modifiers feeding into the loop: the microbiome, the diet, and the intestinal barrier. When any part of that circuit is amplified, normal gut activity gets read as pain. That is the core of functional disease. Notice that the loop runs in both directions. That is why a brain-directed therapy can relieve a gut symptom. 4 mechanisms drive symptoms in irritable bowel syndrome. First, Altered motility. Transit runs too fast, and you get diarrhea. Or too slow, and you get constipation. Second, visceral hypersensitivity. A normal volume of gas is felt as pain because the sensory threshold has dropped. Third, a leaky epithelial barrier with low-grade immune activation, often beginning after an episode of gastroenteritis. Fourth, the microbiome, which shapes fermentation, gas production, and bile acid handling. Symptoms are also modulated by stress, by diet, and by lifestyle. These four mechanisms explain why our treatments look so different from one another. Notice that no single mechanism explains every patient. Here are the criteria. Abdominal pain for 6 months or more, associated with at least 2 of the following 3 features. First, the pain improves with defecation. Second, the pain is associated with a change in stool frequency. Third, the pain is associated with a change in stool form. That is the whole diagnostic test. Now walk back through our patient. 8 months of cramping, relief after a bowel movement, and stools that swing between loose and hard. She meets it comfortably. Think about the subtype while you take the history, because the subtype is what drives the drug you reach for next. One more point. These criteria assume you have already excluded alarm features. We will come back to that. Subtype by the predominant stool form. Constipation predominant, written IBSC, means hard and lumpy stool. Diarrhea predominant. IBSD means loose and watery stool. Mixed, IBSM swings between both. And unclassified, IBSU, does not fit any pattern cleanly. Our patient alternates, so she is mixed. Ask the patient to describe stool form on their abnormal days, not on their good days. Subtype can also shift over time, so revisit it when a patient stops responding. The subtype is not academic. It is the single fact that decides which drug you reach for. One practical note. The Bristol stool chart makes this conversation much easier at the bedside, and it takes under a minute. Every subtype gets the same foundation. Start with education and reassurance, then cognitive behavioral therapy, which has real evidence in this disease. Add exercise, probiotics, and antispasmodics for cramping. Neuromodulators help a great deal, a tricyclic antidepressant or a selective serotonin reuptake inhibitor at low dose. These are used for their effect on gut sensation, not because you think the patient is depressed. Say that out loud to the patient, or they will stop the drug. Then change the diet. Lower fermentable carbohydrates with a low FODMAP diet, and trial a lactose-free diet. Then layer subtype-specific drugs on top. Set expectations early. These therapies improve symptoms. They do not cure the condition. Now the subtype-directed drugs. For constipation, predominant disease, increase fiber, add psyllium, then laxatives, lubiprostone, linaclotide, tegaserod, and tenapanor. For diarrhea, predominant disease, loperamide for symptom control, rifaximin, eluxadoline, bile acid sequestrants, allosetron, and amitriptyline. Notice that amitriptyline appears on the diarrhea side because its anticholinergic effect slows transit, while most of the constipation drugs are secretagogues that pull water into the lumen. Match the mechanism to the stool pattern, and these stop feeling like a list to memorize. One caution: allosetron and tegaserod carry prescribing restrictions, so know your local practice before you use them. Before you settle on irritable bowel syndrome, clear the alarm features. Weight loss, rectal bleeding, anemia, symptoms that wake the patient at night, a family history of colorectal cancer or inflammatory bowel disease, and new symptoms starting at an older age. Any one of those buys a workup rather than a label. Also check a celiac serology and consider inflammatory markers when diarrhea dominates. But the common pitfall runs the other way too. Ordering scan after scan in a patient who already meets criteria and has no alarm features adds cost, adds radiation, and tells the patient you are not sure. Commit to the diagnosis and document your reasoning. A clear note protects the next clinician from starting the whole workup over again. Our second patient is a 22-year-old man. He arrives in the emergency department vomiting. This is his 4th visit in a year for exactly the same thing. Each episode starts in the early morning, lasts about 2 days, and then stops completely. Between episodes he feels entirely well and eats normally. He tells you he uses cannabis daily, and that his mother has migraines. He says hot showers are the only thing that help. On exam, he is tachycardic and dry. His abdomen is soft with no tenderness. Labs show a mild metabolic alkalosis, and an abdominal computed tomography scan last year was normal. What is the diagnosis? Notice how stereotyped the episodes are. That word stereotyped is doing a great deal of work here. This is cyclic vomiting syndrome. The defining pattern is acute recurrent vomiting with completely well intervals in between. Notice the two associations sitting in the history: daily cannabis use and a personal or family history of migraine. Both are classic. The stereotyped episodes, the normal imaging, and the well intervals are what confirm it. Anatomy has already been excluded. Our next step is to rehydrate him, control the vomiting, and then have the conversation about cannabis, because continued use will keep the cycle going. Let us walk through the acute treatment. One more clue. Identical episodes with well intervals are what separate this from ordinary gastritis or an ulcer. Treat the acute episode aggressively. Start with intravenous fluids. These patients are usually dry and often have an electrolyte deficit. Give antiemetics. Then the drug worth remembering, sumatriptan, is first line. The migraine link is not a coincidence. This syndrome responds to migraine therapy. If sumatriptan fails, aprepitant is the next agent, given for 3 days. Benzodiazepines can help break a refractory episode through sedation and by blunting the vomiting reflex. A dark, quiet room helps more than you would expect. Do not stop at the antiemetic order. These episodes end faster when you treat them like a migraine and replace the potassium. Repeated vomiting leaves these patients depleted. Now, prevention. Between episodes, start a preventative agent. A tricyclic antidepressant is the usual first choice, and antiepileptic drugs are the alternative. These are the same classes used for migraine prophylaxis, which again tells you something about the mechanism. And the single most important intervention: have the patient stop cannabis. Chronic use drives the syndrome, and the relief patients get from hot showers is a clue that points straight at it. Counsel plainly. Tell them the vomiting will keep returning until the cannabis stops. Improvement after stopping can take weeks to months, so set that expectation early. Set a follow-up visit. Relapse is common, and these patients often disappear from clinic. Our third patient is a 56-year-old woman with long-standing type 1 diabetes. She reports 6 months of nausea nearly every day, vomiting several times a week, and feeling full after only a few bites. The vomiting sometimes brings up food she ate hours earlier. Her blood sugars have become erratic and hard to control. She takes no opiates. On exam, her abdomen is soft and mildly distended. You hear a succussion splash. There is no tenderness and no mass. An upper endoscopy shows retained food in the stomach, but no obstruction and no ulcer. What is the diagnosis? One more detail. She takes no opiates, which removes the most common drug cause before you order a single test. This is gastroparesis, delayed gastric emptying without any mechanical obstruction. Her endoscopy has already ruled out a blockage. Look at how well she matches the classic picture. Nausea occurs in more than 90% of patients, vomiting in more than 80%, early satiety in about 60%, and postprandial fullness or pain is nearly universal. Vomiting food eaten hours earlier and a succussion splash both point to a stomach that is not emptying. Erratic glucose control is both a cause and a consequence here. The next step is a gastric emptying study to confirm it. Notice also what is missing. No weight loss, no mass, and no obstruction. This is a motility problem. Where does gastroparesis come from? Diabetes is the classic cause, acting through autonomic neuropathy that damages the vagus nerve. Surgery is next, particularly operations near the vagus or the gastroesophageal junction. A post-viral form can follow a gastroenteritis and often improves over months. Critical illness slows the stomach in the intensive care unit. Parkinson's disease and other neurologic disorders do it too. Then the drugs: opiates, calcium channel blockers, and anticholinergics. Always review the medication list before you commit to the diagnosis. And a large share remain idiopathic, with no cause ever identified. And remember that gastroparesis can be intermittent. A normal study on a good day does not exclude it. Watch the normal stomach first. The fundus relaxes to accept the meal. That is receptive relaxation. Then the antrum grinds solids down into small particles. The pylorus opens in a coordinated way and lets them through. The whole process is driven by the vagus nerve and by the pacemaker cells of Cajal. Now compare the delayed stomach on the right. The fundus does not relax well. Antral contractions are weak. The pylorus stays tight, and food simply sits. Notice what that produces clinically: early satiety, fullness, nausea, and vomiting of old food. The mechanics explain every single symptom. Notice one more consequence. Solids empty poorly while liquids often still pass, which is why a liquid diet helps. 2 steps to the diagnosis. First, rule out a mechanical cause. An upper endoscopy is the usual way. You cannot call it gastroparesis until you have shown the outlet is open. Second, perform gastric emptying scintigraphy. The study is positive when solids are still retained at 4 hours. Prepare the patient properly, or you will get a false result. Stop opiates and other agents that slow the gut before the test, and get the blood sugar under reasonable control, because acute hyperglycemia by itself delays emptying. A study done on a patient still taking opiates tells you nothing useful. One practical point. The study must run the full 4 hours. A shorter study will miss disease. Write the order correctly. Treatment starts with diet, small frequent meals that are low in fat and low in fiber. Then prokinetics. Metoclopramide is the standard agent, and erythromycin also works by stimulating motility receptors. Add antiemetics for symptom control. In diabetes, tighten the glucose, and stop every drug that slows the stomach. If the patient cannot maintain nutrition by mouth, place a feeding tube beyond the stomach. For refractory disease, consider a pylorus-directed procedure, botulinum toxin, pyloromyotomy, gastric peroral endoscopic myotomy, or pyloroplasty. A gastric electrical stimulator is another option. And one caution, metoclopramide carries a risk of tardive dyskinesia, so use the lowest effective dose and reassess often. Our fourth patient is a 79-year-old man on the medical ward. He is 4 days out from repair of a hip fracture. He is taking oxycodone for pain. Overnight, his abdomen became hugely distended. He has not passed flatus in 2 days. He has some abdominal discomfort, but it is not severe. He has hiccups and mild nausea. On exam, his abdomen is tympanitic and markedly distended. Bowel sounds are reduced. There is no rebound and no guarding. His potassium is low at 3.0. An abdominal film shows massive colonic dilatation, with gas continuing all the way to the rectum. What is the diagnosis? Notice what is absent: no rebound, no guarding, and no fever. This is not a surgical abdomen yet. This is Ogilvie syndrome, also called acute colonic pseudo-obstruction. Start with the parent definition. A paralytic ileus is the loss of intestinal peristalsis in the absence of any mechanical obstruction. When that failure is confined to the colon and the colon dilates massively, we call it Ogilvie syndrome. The clues here were the age, the recent surgery, the opiates, the low potassium, and gas continuing all the way to the rectum. A true mechanical obstruction would show a cutoff. Our next step is to hunt down every precipitant and to measure the cecum. One more point. The distinction matters because the treatments diverge. A mechanical obstruction goes to the operating room. This one does not. Ileus almost always has a trigger, and finding it is the treatment. Group them into 5 buckets. First, an intra-abdominal process, recent surgery, pancreatitis, peritonitis, or intestinal ischemia. Second, severe illness of any kind. Sepsis is the classic one. Third, medications. Opiates first, then calcium channel blockers and anticholinergics. Fourth, metabolic and endocrine abnormalities, thyroid disease, diabetes, kidney failure, liver failure, and low potassium. Fifth, neurologic causes, spinal cord compression or trauma, Parkinson's disease, Alzheimer's disease, and multiple sclerosis. Our patient hit 3 of those at once. Fix what you can fix. Often that alone resolves the whole problem. Here's why the colon stops. Normal colonic motility depends on a balance. Parasympathetic input from the sacral nerves drives contraction. Sympathetic input inhibits it. Follow the left side of the diagram. Critical illness, surgery, pain, and opiates drive a surge of sympathetic output. Now follow the right side. The same insults suppress sacral parasympathetic tone to the distal colon. Put those together, and you get inhibition with nothing left to drive contraction. The colon goes flaccid and fills with gas. Notice why neostigmine works. It raises acetylcholine and restores the missing parasympathetic push. Notice one more thing. This is why simply waiting rarely works. You have to change the balance. Imaging seals the diagnosis. A plain abdominal film or a computed tomography scan shows colonic dilatation with no mechanical obstruction. In a small bowel ileus, you see dilated loops of small bowel instead. Computed tomography is preferred when you are not certain, because it excludes a volvulus or a mass. Now the number that matters. A cecal diameter greater than 12 centimeters is associated with a high risk of perforation in Ogilvie syndrome. Measure it and write it down. Then follow it with serial films. A rising cecal diameter or new tenderness changes your management from watchful to urgent. And check a lactate and palpate for tenderness. Those 2 findings suggest the colon is already in trouble. Treatment begins with support. Make the patient nothing by mouth. Stop every offending medication. Correct the electrolytes. Decompress with a nasogastric tube from above and a rectal tube from below. Provide nutrition support. For opiate-related cases, methyl naltrexone can help. Then the specific therapy, intravenous neostigmine. Give it with the patient on a monitor and watch closely for bradycardia. Have atropine at the bedside. For Ogilvie syndrome only, colonoscopic decompression is the next step if neostigmine fails. And if the colon remains refractory, surgery follows, a colostomy or a colectomy. And check contraindications first. Neostigmine is avoided with active bronchospasm or a recent bradyarrhythmia. Our fifth patient is a 68-year-old woman. She comes to clinic frustrated. For the past 5 months, she has moved her bowels twice a week at best. She strains every time. The stool is hard and lumpy, and she often feels she is not finished. Twice, she has had to use her fingers to help. She started oxycodone for back pain last year. She also takes a calcium supplement and amitriptyline for sleep. On exam, her abdomen is soft with palpable stool in the left colon. The rectal exam shows normal tone and no mass. Her blood count and thyroid studies are normal. What is going on? Notice what she does not have. No bleeding, no weight loss, no anemia. So this is not a colonoscopy first situation. She has chronic constipation, and it is secondary, driven mostly by her medications. Count them: an opioid, a calcium supplement, and a tricyclic antidepressant. All 3 slow the colon. She also meets the formal definition on symptoms alone. Fewer than 3 bowel movements per week, straining, hard lumpy stools, a sense of incomplete evacuation, and manual maneuvers to assist defecation. She has no alarm features, and her basic labs are normal. The next step is not simply a laxative prescription. It is a real diagnostic frame, so let us define constipation properly. And ask about the pelvic floor. Manual maneuvers hint at an outlet problem hiding underneath. Constipation is defined 2 ways. The practical definition is simply dissatisfaction with defecation. The formal Rome 4 definition requires at least 2 of the following. Present for at least 25% of bowel movements over the last 3 to 6 months. Straining, lumpy or hard stools, a sensation of incomplete evacuation, a sensation of anorectal obstruction, manual maneuvers to facilitate defecation, and a stool frequency of fewer than 3 per week. Notice that frequency is only one of the 6 items. Many constipated patients go every day. Ask about straining and about the sense of incomplete emptying. One more point. Ask the patient what they mean by constipation. Their definition and yours are often very different. Primary constipation splits into 2 mechanisms, and they are treated very differently. Follow the left path. Slow transit constipation. The colon itself moves stool too slowly. Look at the transit study on screen. Markers remain scattered throughout the colon at the end of the study. Now the right path. Pelvic floor dyssynergia. Colonic transit is normal, but the outlet fails. The puborectalis and the external sphincter contract when they should relax. Markers pile up in the rectum. That patient needs biofeedback therapy, not more laxatives, which is exactly why the diagnostic workup matters. One clue at the bedside. Ask the patient to bear down during the rectal exam. Paradoxical contraction is the finding. Before you call it primary, rule out secondary causes. Use the 4M framework. Mechanical obstruction, malignancy, extrinsic compression, rectocele, and strictures. Medications, opioids, tricyclics, anticholinergics, calcium channel blockers, non-steroidal anti-inflammatory drugs, diuretics, calcium, iron, and a low-fiber diet. Metabolic and endocrine causes, diabetes, hypothyroidism, uremia, pregnancy, panhypopituitarism, porphyria, high calcium, low potassium, and low magnesium, and myopathy or neurologic disease, Parkinson, Hirschsprung, amyloid, multiple sclerosis, spinal injury, and dysautonomia. Work this list before you reach for a laxative. The answer is very often sitting on the medication list. The workup starts with the history and physical. And the digital rectal exam is not optional. It tells you about tone, about a mass, and about whether the pelvic floor relaxes when the patient bears down. For labs, consider a complete blood count, electrolytes including calcium, and a thyroid-stimulating hormone level. Get a colonoscopy if there are alarm symptoms. When simple measures fail, move to physiologic testing, anorectal manometry with a balloon expulsion test to find dyssynergia, a colonic transit study to prove slow transit, and defecography when a structural outlet problem is suspected. And do not skip the history. How long, how often, and what the stool actually looks like. Tell you more than any test. Now the ladder. First line is behavioral and simple. Increase fluid, increase fiber, increase exercise, and add an emollient laxative such as docusate to soften the stool. Second line adds 3 drug classes. Bulk laxatives, psyllium and methylcellulose, increase colonic residue and peristalsis. Stimulant laxatives, senna, castor oil, and besicodyl, increase motility and secretion. Osmotic laxatives, magnesium, sodium phosphate, and polyethylene glycol, pull water into the colon. Avoid sodium phosphate in chronic kidney disease. Third line is an enema, or a suppository. Set the expectation. These agents work best taken consistently rather than only on bad days. And pair fiber with fluid. When all of that has failed, you still have real options. Linaclotide increases stool frequency and reduces straining and bloating. Lubiprostone increases intestinal secretion. For opioid-induced constipation, use methylnaltrexone or alvamopan. These block the peripheral opioid receptor without touching analgesia. For chronic idiopathic constipation, plecanatide, a cyclic GMP agonist, or prucalopride, a serotonin receptor agonist. Match the drug to the cause rather than adding another laxative on top of the last one. And do not simply stack laxatives. Adding a 4th agent on top of 3 that failed rarely helps. Reassess the mechanism instead. Our last patient is in the intensive care unit. A 62-year-old man admitted this morning with severe pneumonia and septic shock. He is intubated and sedated. He is on a moderate dose of norepinephrine, and his blood pressure is now stable. His lactate is falling. His abdomen is soft and not distended. He has bowel sounds. There is no obstruction and no gastrointestinal bleeding. The nurse asks you the question every resident gets asked. Should we feed him? And if so, how? And when? Think about the route, the timing, and about what would make you hold off. Think about what you would want to know before you answer. The abdomen, the shock state, and the timing. Those 3 decide it. Feed him, and feed him through the gut. Starting enteral nutrition within 48 hours of intensive care unit admission may reduce infection and mortality. His shock is now controlled, his abdomen is benign, and there is no obstruction and no bleeding. So nothing is holding you back. Here is the point that surprises people. Enteral and parenteral nutrition produce similar clinical outcomes overall. So the argument for using the gut is not really about calories. It is about avoiding line infections, maintaining the gut barrier, and preserving enteric stimulation. Now let us look at when you cannot use the gut. And start at a low rate. You can advance as tolerance allows. Even trophic feeds protect the gut. Enteral nutrition has 3 clear contraindications: bowel obstruction, major gastrointestinal bleeding, and uncontrolled shock. Note the word uncontrolled. A patient on a stable low-dose vasopressor can usually be fed. A patient whose blood pressure is still crashing should not be. And that brings us to the most feared complication: ischemic bowel. Feeding raises the demand for splanchnic blood flow. If perfusion cannot rise to meet that demand, the gut can infarct. Other complications are far more common: aspiration, pneumonia, and metabolic abnormalities. Watch the residuals and elevate the head of the bed. And do not defer feeding for days while you wait for perfection. Reassess every single morning. Now, parenteral nutrition. The timing rule is simple. Start it after about 7 days if the patient still cannot tolerate enteral feeding. There is no clear benefit to starting it early, so resist the urge to hang it on the first day. The contraindications are metabolic, hyperosmolality, severe electrolyte disturbances, and severe hyperglycemia. Sepsis is a relative contraindication, not an absolute one. Correct the metabolic derangements first, then start. And remember that the whole time you are running parenteral nutrition, you have a central line in a critically ill patient, which is where most of the trouble comes from. And once the gut becomes usable, transition back. Parenteral nutrition should end as soon as it safely can. The complications of parenteral nutrition fall into 3 groups. First, metabolic hyperglycemia is the most common, and refeeding syndrome is the most dangerous. Watch phosphate, potassium, and magnesium closely over the first days. Second, catheter-related sepsis with a raised risk of fungal infection and catheter-associated thrombus. Third, hepatobiliary, abnormal liver tests from steatosis and cholestasis, and gallbladder sludge. That last one has a specific cause: the lack of enteric stimulation. Nothing is entering the gut, so the gallbladder never contracts. Even trickle feeds help. One last point. Start with modest calories in a malnourished patient. Overfeeding is what precipitates refeeding syndrome. Let us close with the points you cannot miss. Irritable bowel syndrome is a positive diagnosis, but clear the alarm features first. Cyclic vomiting syndrome responds to sumatriptan and will not resolve until the cannabis stops. Gastroparesis requires ruling out obstruction before the emptying study, and the study is positive when solids remain at 4 hours. In Ogilvie syndrome, a cecal diameter greater than 12 centimeters flags a high risk of perforation. In constipation, work the 4 megaseconds before you call it primary. And in critical illness, feed the gut within 48 hours whenever you safely can. And across all 6, look at the medication list first. It is the most common reversible cause in this whole hour. These are the sources behind this session. The Rome 4 Criteria for Functional Gastrointestinal Disorders, published in Gastroenterology in 2016. The American Gastroenterological Association Guidelines on the Pharmacologic Management of Irritable Bowel Syndrome. The Nature Reviews Disease Primers, Reviews of Gastroparesis and of Constipation. The American Society of Colon and Rectal Surgeons Guideline on Paralytic Ileus. The Joint Guideline on Chronic Idiopathic Constipation. And the critical care nutrition literature comparing the enteral and parenteral routes. Thank you for learning with us. Every recommendation here follows current guideline consensus. Look them up when you need the detail behind a recommendation.